Chapter 7, Nonmaleficence, Introduction. Today we turn to a principle that lies at the very heart of medical ethics, nonmaleficence, the obligation to do no harm. This idea traces its roots to the Hippocratic Oath, which for centuries has guided medical practitioners. First, do no harm. In healthcare, the call to do no harm is not simply a suggestion, it is a binding ethical duty. It means that in all our actions we must avoid causing unnecessary injury, suffering, or loss. Nonmaleficence is not only about avoiding harmful acts, it's also about avoiding harmful omissions, times when failure to act can itself cause harm. This chapter will explore what nonmaleficence means in modern healthcare, how different ethical theories interpret it, and the challenges we face in applying it to real-world cases. 1. Defining nonmaleficence. Nonmaleficence means not inflicting harm intentionally. In practice, it obligates healthcare providers to refrain from actions that would cause injury, worsen a patient's condition, or deprive them of needed care. This principle is closely linked to beneficence, which focuses on actively doing good. Together, they create a moral balance. We must promote well-being while ensuring our actions do not cause harm. Importantly, harm can be physical, emotional, psychological, social, or even spiritual. For example, administering the wrong medication, physical harm, using words that belittle or humiliate a patient, psychological harm, ignoring a patient's spiritual needs, spiritual harm. Non-maleficence requires a careful weighing of risks and benefits before taking any action. 2. Ethical frameworks and non-maleficence. Different ethical theories approach the principle of non-maleficence in distinct ways. Utilitarianism. Avoid harm because harm reduces overall happiness. The right action is the one that minimizes suffering and maximizes well-being for the greatest number. Deontological ethics. Avoid harm because it is a duty, regardless of consequences. Harming others is wrong in itself. Rights-based theories. Avoid harm because every individual has an inherent right not to be harmed. Virtue ethics. Avoid harm because a person of good character acts with compassion, prudence, and respect for others' well-being. Principalism. Non-maleficence stands as one of the 4 foundational principles, alongside autonomy, beneficence, and justice, guiding ethical medical practice. Understanding these perspectives helps us apply non-maleficence thoughtfully in diverse clinical settings. 3. Letting patients die versus non-action. In end-of-life care, non-maleficence plays a central role in deciding when not to intervene. 2 important concepts arise. Letting patients die. Choosing not to prevent death when treatment would only prolong dying without improving quality of life. Example: honoring a do not resuscitate (DNR) order in a terminally ill patient. Non-action, omission, choosing not to initiate treatment due to futility, excessive burden, or lack of benefit. Example: deciding not to perform dialysis on a patient with multi-organ failure and no chance of recovery. While both involve withholding treatment, the ethical reasoning differs, and both demand clear communication with the patient, if possible, and family. 4. Harm through omission. Harm can occur not only through direct actions, but also through failure to act when action is needed. For instance, not providing pain relief to a suffering patient when appropriate, neglecting to monitor a patient after surgery, failing to act on abnormal lab results. Non-maleficence demands that we guard against harmful omissions as much as harmful acts. 5. Proportionality, balancing risks and benefits. Medical interventions almost always carry some risk. The ethical challenge is deciding when the potential benefits outweigh the risks. Examples: a chemotherapy treatment that could prolong life but causes severe side effects, a risky surgery that offers a chance of recovery versus conservative management with less risk but also less benefit. Non-maleficence doesn't require eliminating all risk, it requires avoiding unnecessary or disproportionate risk. 6. Feminist ethics and avoiding harm. Feminist ethics reminds us that harm is not just about isolated actions, it is also shaped by systems and structures. For example, discrimination in care delivery can harm marginalized patients. Gender bias in medical research can result in harmful treatment gaps. Social determinants of health, like poverty and inequality, can cause systemic harm. Applying non-maleficence means recognizing and working to dismantle these structural harms. 7. Special applications of non-maleficence. A. End-of-life decisions. When treatment causes more suffering than benefit, non-maleficence supports shifting to palliative care. Example: choosing comfort care over aggressive interventions in advanced dementia. B. DNR orders. Respecting a patient's DNR order prevents unnecessary, potentially traumatic resuscitation efforts that would not meaningfully improve quality of life. C. Resource allocation. In a crisis, non-maleficence may justify not initiating treatment for patients with little chance of survival if doing so would harm others by diverting scarce resources. D. Experimental treatments. Introducing high-risk experimental interventions without strong evidence of benefit can violate non-maleficence. 8. Case studies. Case 1. Chemotherapy in advanced cancer. A patient with advanced cancer is offered a new chemotherapy with severe side effects and only a small chance of extending life by a few weeks. Beneficence says, try to prolong life. Nonmaleficence says, avoid causing suffering for minimal benefit. In this case, the harm may outweigh the benefit. Case 2. Ventilator allocation during a pandemic. 2 patients need a ventilator. Only one is available. Providing it to the patient with the lowest survival probability might cause harm by denying it to the one more likely to survive. Case 3. Pediatric pain management. Withholding pain medication out of fear of addiction can cause unnecessary suffering and violate non-maleficence. 9. Ethical decision-making with non-maleficence. When applying non-maleficence, identify potential harms of action and inaction. Weigh harms against potential benefits. Consult the patient's values and wishes. Involve the healthcare team in discussion. Document the reasoning for transparency and accountability. 10. Interplay with other principles. Non-maleficence often overlaps and sometimes conflicts with autonomy, respecting patient choices even when they may lead to harm. Beneficence, promoting good while avoiding harm. Justice, ensuring harm is not disproportionately borne by one group. The art of medical ethics lies in balancing these principles. Closing reflection. Non-maleficence is more than a phrase from an ancient oath. It is the moral compass that keeps healthcare aligned with its deepest purpose, to heal, to comfort, and above all, to do no harm. As healthcare providers, our challenge is to act boldly for the good of our patients, while vigilantly guarding against harm, whether from our hands, our words, our omissions, or the systems we work within.